This program is brought to you by Community Trust Bank, Medical City, Bid Select, and the Neely School of Business at TCU. Welcome to Platforms, the life-lifting news program for women. Now, here's your host, Siobhan Palmer.
Welcome back, everybody, to Platforms, the life-lifting news program for women. We're broadcasting here from the beautiful Medical City Children's Hospital in Dallas, and the topic of today's show is minimally invasive surgery. We have Dr. Anh-Hong Tran, who is a board-certified urologist with Dallas Urology Associates. Dr. Tran, welcome back.
Thank you.
When we went to break, we were talking about kind of the background, the history of laparoscopic surgery, and it's really revolutionized a lot of methods for surgeons. And now you were talking about robotics as a supplementer.
I think a lot of patients have misconceptions about robotic surgery.
Yes.
I think people tend to think that it's a machine that's operating on them, and that's far from the truth. When you're involved in a robotic case, it's the surgeon who's doing the operation. It just happens to be that he's at a console using a remote controlling device. The patient is oftentimes in the same room, although we've heard of the surgeries that have been done transcontinentally.
Yes, which is remarkable.
Yeah. And but usually here, the surgeon is in the same room. The patient is on a special operating room table, and they've had small incisions through which the instruments are introduced, and the instruments are attached to robotic arms. And I brought some instruments just to kind of show you the evolution of, the type of instruments we use in surgery. Let's just start from the very beginning. This is the type of needle driver that you would use in an open surgery. You can see it's like scissors in a sense that, it responds to the way your hand is moving. Right. And you're limited by what you can see and by your wrist motion.
So you would use this in conventional surgery where
in
you have to do
conventional surgery,
okay.
If I am suturing where I'm sewing together something, the needle is in here. This is just one of the instruments. And you can see my wrist motion. I have a good range of motion, but it is somewhat limited.
Okay.
And when you translate to, conventional, traditional laparoscopic surgery, we are operating not through an open incision, but through smaller, little access incisions. And so our instruments have to be longer because we're going in through these holes to get to them. And it's a very similar principle. You're operating it, you have your handle here, and you can rotate your instrument. So because you're not inside, you can't mobilize inside.
Right.
But it's pretty much you're limited by your range, your wrist motion as well.
Okay.
And that's where the advantages of the robot comes in, because with the robot control, the range of motion is so much greater than what your wrist is able to afford. I wish I could demonstrate it here, but this is the device that attaches to the robotic arm. This, you can see, it looks very similar to this handle. And then down here, it's almost like a set of pulleys, where multiple different pulleys that allow you to rotate this, and it's almost like if your wrist was disjointed and you could really move it
360, you have a whole
almost to that degree. Yeah, so it's a finer range of motion. The other benefit of the robot is that you can really visualize things much better. You can magnify up to 10 to 15 times what the normal eye can see.
Wow.
So when you're working on delicate structures, for instance, in robots in prostate surgery, where we're trying to preserve the nerve that allow men to have erections, sometimes you can even see the bundles of nerves. And
wow.
And so that way you can just make sure you're dissecting it off and preserve it. So that's one of the real advantages of robot surgery. The other is because you can visualize so much better.
Right.
You can have finer control of blood loss.
Is the entry point for all these surgeries, doctor, do you always go through the belly button, or are there other entry points depending on where the surgery is located?
That's a very good question. For most of the surgeries, we tend to gain our access. We use a needle to get into the abdomen, and we have to inflate it with air in order to have a wider space to work in. The belly button tends to be the shortest distance into the abdominal cavity, so that's why oftentimes when you see pictures of robot surgery, you see an access there. But it can be anywhere. You can get in access anywhere, and you put your instruments, the access site for the instruments, where it's going to be the easiest to maneuver the instruments and be able to get to where you need to go.
What are some of the more common procedures you're doing as a urologist, a surgeon doing urology?
Sure. That's a great question, because I think more and more patients are becoming aware of robot type of surgeries, and they are asking for it. And the one area where patients are starting to demand it is prostatectomies for prostate cancer. We all know that most men will have it at some point in their lives, and the type of surgery, it historically has been open. It started to be done robotically around 2000, and at that time in that year, 65 robot prostatectomies were done. Last year, about 75,000 robot prostatectomies were done.
75,000.
75. That's about 85% of the prostate surgeries were done robotically. So the field is really heading in that direction. The other surgeries that we do are removing the kidney for cancer, doing partial removal of tumors in the kidney, reconstructing the kidney collecting system. These are very delicate surgeries, and having that range of motion that I spoke about with the robot arm really facilitates things. Having that greater visualization really allows you to have possibly better outcomes.
Right. Where do you see laparoscopic technology going, say, in the next 4 to 5 years? It seems like the possibilities are kind of endless in terms of improving on this technology.
Sure. One of the latest things that have started to come out in the last couple of years, it seems like we're trying to become more and more minimally invasive.
Yes.
Whereas with these surgeries that I've described, historically you've had at least three incisions, one for the camera, two for the different instruments that you're working on. We're starting to do what are called single access laparoscopic surgeries, where you have one incision and you put all of your instruments through that one incision. And they're also talking about other things such as natural orifice laparoscopic surgery, where instead of creating a hole that is visible, you're going through an orifice such as the vagina or the stomach, where you already have an opening and you can access that, and then there's no visible incision on the outside. So those are some of the areas where the latest cutting edge research is being done.
There's one, I know you're going to have to help me pronounce this,
sacrocolpopexy.
Yeah, there we go. We're going to all say that 3 times together. Tell me about that procedure.
Just to break it down, sacrum, if I can just show you the diagram again,
Absolutely.
I think it makes it easier. I didn't get a chance to kind of orient this diagram. Back here is where your buttock would be, and here is where your tailbone is.
Right.
And the sacrum refers to essentially the tailbone area. So in sacrocolpopexy, sacro refers to the sacrum, the tailbone. Colpo refers to the vagina. And pexy is kind of you're pexing something somewhere. So in cases where there's prolapse of the top portion of the vagina, for instance, in a woman who's had hysterectomy, just because of the surgery, you're losing a lot of the usual structures that provide support.
Right.
Oftentimes, the gynecologists recognize this, and this is something that they've really tried to study. So what you will see is that the vaginal vault starts to come down, so the top part of the vagina starts to come out. Depending on the degree of prolapse, the gold standard surgery, if it's a large symptomatic descent, is to tack the vagina, copal in sacrocolpopexy, to the sacrum using a piece of mesh, which is a very soft,
pliable
material.
type, yeah.
Exactly.
Yeah. Dr. Tran, could you hold that?
Absolutely.
We've got to go to break. When we come back, we'll continue this conversation. It's fascinating information. We're broadcasting from Medical City Children's Hospital in Dallas, and this week's show topic, minimally invasive surgery. This is Siobhan Palmer with Platforms, a life-lifting news program for women.